Hello, my name is Max Fisher, and this summer I did research in the Department of Orthopedic Surgery with Dr. Fisher-Grindel. We looked at how postoperative ranges of motion in reverse total shoulder arthroplasties can be predicted using three-dimensional planning software. To provide a little bit of background, reverse total shoulder arthroplasties have the ability to significantly improve the quality of life of those suffering from primary osteoarthritis of the glenohumeral joint. These patients often have severe pain and very reduced ranges of motion in their shoulder, and therefore can't perform their daily activities as they would like to. However, we don't know postoperatively if all patients are able to take full advantage of the ranges of motion provided by their new shoulder replacement. We hypothesized that the computer-predicted range of motion will statistically correlate with the actual postoperative measured range of motion. Using a retrospective chart review, we studied all patients who had received a reverse total shoulder arthroplasty from December 2016 until now. We excluded patients who had complications such as a fracture, infection, reoperation, or patients who were recurrent dislocators. We then recorded preoperative and postoperative ranges of motion for the values of forward flexion, external rotation with the arm at the side, external rotation with the arm at 90 degrees, internal rotation, adduction, and abduction. For the computer-predicted ranges of motion, we recorded values for forward flexion, external rotation with the arm at side, and abduction. The software takes the CT data and makes a three-dimensional reconstruction of the glenohumeral joint, as seen in Figure 1. It then allows the surgeon to place the prosthesis within the CT data, as shown in Figure 2. After the surgeon has placed the prosthesis in the CT data, the software then extrapolates that information into the three-dimensional reconstruction of the glenohumeral joint, as seen in Figure 3. The software allows for the surgeon to fine-tune the placement of the prosthesis to allow for maximum range of motion. The software calculates the ranges of motion based off of impingement on bony anatomical landmarks within the CT scan. We also recorded demographic information on the patients, such as gender, laterality of the surgery, BMI, and other comorbidities. We then calculated the positive predictive values for the three computer-calculated ranges of motion: forward flexion, external rotation with the arm at side, and abduction. When comparing these values to the actual postoperative ranges of motion, we found that both forward flexion and abduction had a statistically significant negative correlation with p-values of 0.0128 and 0.00663, respectively. However, we did not find external rotation with the arm at side to have any predictive value. While this data contradicted our hypothesis, it does demonstrate that the patient's actual postoperative range of motion will exceed the range of motion predicted by the planning software. This information is very useful in that the surgeon will be able to guide the patients preoperatively and manage their expectations, knowing that their ranges of motion postoperatively will be able to exceed the computer-predicted value. However, if a patient is not meeting their expected range of motion goals during routine follow-up, it may indicate that there's an issue with their prosthesis, they are not adhering to their physical therapy schedule, or there may have been an additional injury to the shoulder joint. In the future, we would like to get a qualitative assessment of how patients' satisfaction with their shoulder replacement correlates to actual postoperative ranges of motion. Additionally, we would like to see how comorbidities and preoperative ranges of motion affect postoperative ranges of motion, which we will be able to see when our data is finished being analyzed by the Department of Biostatistics. I would like to thank Dr. Richter and Dara for their invaluable feedback throughout this research process, and I would also like to thank Dr. Tarima in the Department of Biostatistics for his help in processing our data. Thank you to the Department of Orthopedic Surgery for funding this research.